linking membrane function test to survival in peritoneal dialysis patients. In this study, which was done in 2006, there was good evidence to show that patients using CAPD had an increased mortality associated with high solute transport. And this was the first clear evidence that the peritoneal equilibration test was providing prognostic information about patients on peritoneal dialysis treatment. It shows in a more recent cohort of patients that again high solute transport is a predictor of increased mortality, technique failure and hospitalization in a large number of patients treated with peritoneal dialysis in the United States. If we look at the top 3 panels, which each measure solute transport characteristics on their x-axis, it can be seen that once the solute transport rate increases above around 0.75, that there is an increased risk of mortality, technique failure, and hospitalization. The lower 3 panels look at the ultrafiltration capacity of the membrane obtained using a 2.27 or middle strength glucose exchange. Again, you see, particularly for technique failure and hospitalization rates, that a poor ultrafiltration capacity, something less than 100 mils at the end of the peritoneal equilibration test, is also associated with worse outcomes. Sense that the increased risk of problems in high solute transport patients is in part due to the fact that they get less good ultrafiltration. To optimize ultrafiltration in high solute transport patients, then 2 things can be done. They can be treated with automated peritoneal dialysis. This allows us to shorten the lengths of the exchange and therefore reduce the risk of the loss of osmotic gradient during the course of the dwell. Data to support this comes from the ANS data registry and also from the DaVita database shown on the previous slide. In both cases, you can be seen that the use of APD in patients with high solute transport is associated with a reduction in that mortality risk. The other strategy that can be used to prevent the fluid reabsorption that might occur during the long dwell of a patient on APD would be to use either a larger glucose concentration or to use the polyglucose solution icodextrin, which enables sustained ultrafiltration in patients regardless of their solute transport characteristics. This slide shows how the peritoneal equilibration test data can be used to monitor patients' membrane function longitudinally with time on treatment. This is taken from a single cohort of patients treated in my own centre, where you can see that over time there tends to be an increase in the solute transport characteristics combined with a reduction in the ultrafiltration capacity of the membrane. This reduction in the ultrafiltration capacity initially follows the regression line shown in the light grey and therefore can be explained by the reduction in ultrafiltration capacity that happens as a result of an increase in solute transport. These changes observed in longitudinal membrane function are thought to be representative of changes in the membrane characteristics and morphology that occur with time on treatment. The top left picture shows a normal membrane at the start of treatment. This shows the increase in vascularization of the peritoneal membrane that is known to happen with time on treatment and is thought to be the main explanation for increasing solute transport that occurs with time on treatment. It will be noted that the reduction in ultrafiltration capacity after about 48 months of treatment is associated with a more rapid reduction in the ultrafiltration capacity than can be explained by the increase in solute transport. This disproportionate drop in ultrafiltration is thought to be due to more serious membrane injury. This more serious reduction in ultrafiltration is thought to be due to an increase in peritoneal membrane fibrosis, as shown in the right-hand picture, and this disproportionate fall in ultrafiltration is considered to be a serious prognostic marker for encapsulating peritoneal sclerosis. There are a number of strengths that increase the value of applying the peritoneal equilibration test in clinical practice. It's a test that's very easy to do, especially when limited to a 4-hour test and part of a routine practice or culture within the peritoneal dialysis unit. It's a very reproducible measurement, particularly of solute transport, and in this particular measurement one would expect an error of less than 10%. Finally, I've shown you that this test is now clinically validated and has real value both in terms of dialysis prescription and also for screening patients in identifying ultrafiltration failure and also in identifying progressive membrane injury that might result in a need to switch the patient from PD to hemodialysis. The equilibration test does have some weaknesses. First of all, it's important to remember that solute transport characteristics don't necessarily easily fit into slow, rapid, high or low categories. It's a continuous variable, and so when you're thinking about a patient being a high transporter or a rapid transporter, then the next time you measure them, they may have switched categories, but actually their membrane function may be rather similar. Secondly, we must remember that ultrafiltration capacity measurement does have a significant error in this test. Typically this is around 25%, but it does vary considerably between patients and is usually due to variable catheter function in some individuals. Patients who have very stable catheter function will tend to have a much reduced ultrafiltration capacity measurement error, but in those that have very variable catheter function, you can often be misled by that measurement. Therefore, it's important that this measurement is always interpreted in the context of the overall membrane function and capacity, and should not be over-interpreted when there's no other accompanying clinical problem. It's also important, as already mentioned, that in calculating the ultrafiltration capacity, that you consider the overfill of the dialysis bags, remembering that this could lead to an overestimate of ultrafiltration capacity if it is not properly accounted for. Finally, although we've demonstrated that the peritoneal equilibration test is a useful tool for identifying a low efficient membrane, it does not diagnose the cause of this. This does require more sophisticated tests. For example, a double mini-PET or simply measuring the sodium dip at 1 hour might help you understand better what the cause is of membrane function. Finally, it tells us little about long exchanges and how well, for example, icodextrin will work. For this, it will be necessary to undertake proper assessment of how well a long exchange is being managed, and in particular whether a patient is reabsorbing fluid at the end of an exchange. This is important as even with icodextrin, this can sometimes occur and can be a sign of a patient having a peritoneal leak or other abnormality of catheter function. Is a well-validated and easily implemented tool in the clinic, and it can be used to diagnose and screen for membrane function problems. It is recommended that in most patients that this study should be done at around 6 weeks after starting peritoneal dialysis, and the reason for this is that the membrane is a little unstable during the first few weeks of treatment due to varying degrees of post-operative inflammation. It is important to recognize that membrane function does change in some patients over time. So a repeat test, when clinically indicated, will help identify any clinically meaningful change. It cannot be recommended, however, that all patients have regular tests, say every 6 months, as this is a very large workload and has not been demonstrated to be of consistent value. Finally, it should be remembered that it is a screening test, not a final diagnostic test, and if a full understanding of the cause of membrane failure is required, then additional tests, in particular a sodium dip test at 1 hour, will be useful in determining the cause of any ultrafiltration problems. So to summarize, the peritoneal filtration test is a well-validated and easily implemented tool in the clinic, and it can be used to diagnose and screen for membrane function problems. It is recommended that in most patients that this study should be done at around 6 weeks after starting peritoneal dialysis, and the reason for this is that the membrane is a little unstable during the first few weeks of treatment due to varying degrees of post-operative inflammation. It is important to recognize that membrane function does change in some patients over time. So a repeat test, when clinically indicated, will help identify any clinically meaningful change. It cannot be recommended, however, that all patients have regular tests, say every 6 months, as this is a very large workload and has not been demonstrated to be of consistent value. Finally, it should be remembered that it is a screening test, not a final diagnostic test, and if a full understanding of the cause of membrane failure is required, then additional tests, in particular a sodium dip test at 1 hour, will be useful in determining the cause of any ultrafiltration problems.